Going to give each of our panelists one question, and then I'm going to open it up. But I'm going to also invite the panelists to think of questions for one another, because we got three very interesting and quite different perspectives on different aspects of healthcare, health insurance, and so forth. I'm going to start with Leonard, and I feel bad because Leonard sent me 5 excellent questions, all of which I love, but I'm going to ask him a different one. But I think it's not a totally different one. You talked a bit about Medicaid. And I want to ask you about that program, because that one seems to be, this came up at the end in Saum's presentation, Medicaid managed care companies, big negative return, partly because I think the expectation that the Medicaid expansion may be repealed. So I think there's a sense that with Medicaid, so Medicaid is now the largest program in the US in terms of number of recipients. There are 73 million people in the US who get their health insurance through Medicaid. And the share on that program varies enormously across states. So one possibility is that we move to a kind of block grant situation. Now, there are 30 states that expanded Medicaid, 20 states that did not expand Medicaid. And states vary a lot in how much they spend on Medicaid. So I think there are a lot of people, governors included, or people in states or on the front lines of healthcare, who would like to have more flexibility to design their Medicaid programs and might be receptive to a block grant. But the magnitude of the block grant, how much does each state get? I think the devil is in the details on that, because you have some states, if you're Texas and you didn't expand, versus California and you did expand, Texas might be a little unhappy if per person California ends up getting dramatically more in a block grant. And I actually asked one of my students to put together some numbers in terms of the fraction of people in each state who are on Medicaid. So Utah is actually low in terms of Medicaid. It's about 10.5%. And you can go up the spectrum. You go to Nevada, 21.5% of the state is now on Medicaid. Colorado, 25.5%. California, 31%. New Mexico, 37% of the state is on Medicaid. So if we were to move to block grant, so 37% of people who reside in New Mexico get their health insurance through Medicaid right now. So if we move to block grant and you're New Mexico, you want a big block grant. You're Utah, though, you think, well, what about us? So they elected not to expand Medicaid, and there's obviously differences in incomes across states and so forth that drives part of that. How do you, I see that as being, do you think this block grant thing, do you see that as being a problem as we get into it?
Well, a little preface, and I think the last speaker made a very good point. It's not all about legislation.
Absolutely.
Healthcare is not all about legislation, but Medicaid is a federal law, and the Medicaid program is a joint federal and state program. So it is all about legislation and all about how governments are going to function. The point I want to make is that in healthcare legislation is not about healthcare. That is not what is discussed. There are 3 things that are discussed. The first, the most important, is money, and that's the point you're making. Who gets what?
Right.
Okay? The second, and the one that I think is going to be most important to this administration, is what is the appropriate role of government? Okay, we're talking about population health, and we might all agree that it makes sense for everybody to go once a year for a preventive care checkup. Well, there are people in this country that, what the hell are you talking about? It's my life. You know, I can decide to go or not go, and if I want to spend my money on beer, I'll spend it on beer, okay? So, the notion of government getting involved in healthcare causes a lot of debate that's got nothing to do about healthcare, has to do with rights and what's the role of government and a bunch of other things that we don't have to get into. And the third thing, and this is always a very weird undercurrent, is social beliefs, and that's a term I'm trying to use to neutralize it. And the biggest one is abortion. Okay, I mean, you and I are talking about Medicaid.
Right.
Let me tell you, there are members of Congress, when you say Medicaid, all they hear is abortion, and they have very strong views. The vice president-elect has very strong views on abortion. If you don't think that's going to be part of Medicaid decisions, you miss the boat, and so does the secretary-designate. So I'll be happy to respond to your question, but it's got less to do with health care than it has to do with these other 3 things.
But money.
Okay, well, money is important. Now, the the folks that are in control of government now, the Republican White House and Republican Congress, to the extent they're still Republicans, I don't want to offend anybody, I don't know if that's the term everyone would agree on, but allegedly more conservative, by and large, one of their views about money is that the federal government spends too much of it, and consumers should spend more of it. Okay? Individuals should spend more of it, and that the government's role is too big every place, but particularly in healthcare. So, and the federal government is the worst kind of government. You know, this is Thomas Jefferson. That government which governs least governs best. So the idea is block grants move the authority from the federal government to the state government, which is closer to the people. Okay? That's the big logic. The issue, and you're picking up on what the undertone will be, is wait a minute.
Right.
You know, there's X amount of money in the pot, and California is getting all this money because they cover all these people, which in X state, shall go nameless, we don't cover.
Right.
So why are federal dollars flowing, okay, someplace else? Worse yet, if you look at California compared to X state, California covers all kinds of people who ought to be out working for a living and ought to be getting their health insurance through their employers or some other way. Okay? So that's a strategy that is putting money in the pockets of people who don't deserve it. And I don't want to offend anybody, but that's what some of the logic is. So there will be an attempt to do it for the reasons I mentioned. It appeals to some of the conservative logic, but there'll be pushback. And the most dramatic pushback inside the Republican Party will be Republican governors who do not want the second year of the block grant to have less money in it than the first year. Now, what the vice president-elect is going to do, and I think he'll be sent out literally to state capitals to deliver this message, is if you get a block grant, and if we now allow waivers, and under the ACA and under the Medicaid law, the federal government can waive certain policy considerations and let the state make the decision. If you use the waivers the way we did in Indiana, you can reduce costs, okay? And allegedly you can. You also reduce coverage, and you also create political problems. A lot of people are going to be unhappy. Some number of that 70 million plus that you mentioned are going to be unhappy. But query, do those people vote? Okay? And that's the last rule, that's the first rule of American politics, get reelected.
Right, right.
Okay? So I think there will be changes. I think you will see something approximating block grants, and I think you will see a huge shift to state level regulation. Sorry for the long.
No, it's great, it's great. Okay, so Charles, question for you, swooping in on a somewhat different topic. So you talked a lot about influencing provider behavior and some of the challenges associated with that. When you look, Intermountain really stands out. I mean, long before I met you or was introduced to you, it was pointed out, I've heard lots about Intermountain just being this place that delivered incredibly high quality care. So whatever you were doing there, it rippled all the way. I lived in Pennsylvania and Maryland, and not out where Intermountain has a big presence, but heard wonderful things, and here in the Bay Area too about it. And so one question I have for you is, when we think about getting to a better place in terms of some of the things you talked about, delivering care better, but also helping people live healthier lives, do you think the big obstacles are for health systems and providers in determining what works, or convincing the people on the front lines that what the data say works does actually work?
Yeah, definitely the latter. I've said for many years, and I firmly believe this, that if we could consistently in the United States, starting tomorrow, do every time what we already know works, we would do more to prolong lives, improve life quality, and reduce costs than anything we're going to discover in the lab for the next 10 years. And I've had people come up to me afterward and say, oh, you're such a Luddite, you don't believe in new things. And that's not true. I'm a surgeon. I like new stuff. But we just don't, in the United States, do what we already know works. And so what's hard about it It's for providers. I mean, I think some administrative people who don't have a deep clinical background, they just think, well, doctors are either lazy or ignorant, or they have self-serving interest to continue to do things the old ways. I don't think that's general. Like I said in my remarks, doctors want to have better outcomes for their patients. And I think what makes it hard for them to change is if they're not convinced that that change, just like in the example I gave, is going to really make a difference. But if you can show them with baby steps that, hey, you adopted this best practice, look how our outcomes improved, they get engaged. And when you get to the point where in a division or a department, they say, oh, wow, look, we did this, and now our outcomes are as best as anybody reported in the world, they start looking for other ways to do that.
Great. Okay. And my last question is for Saum, and then I'm going to open it up to the audience. So in terms of you, at McKinsey, you talk with employers all the time who deal with these questions of healthcare costs and their employees and trying to structure things, assuming somewhat better, so that they work better for their workers and control costs somewhat better. I mean, do you see them as being a powerful force going forward for us to get cost growth under control? Or do you think some of these innovations that are happening in the sort of background are instead the more powerful agents of change in this space? And are you optimistic? Last sort of three questions in one.
It's a good question. Well, first of all, I think employers are already an important force in the healthcare economy. Like I said, they're the non-government source of subsidy.
Yeah.
So they are an incredibly powerful force. I would back up a little bit from this discussion of what are the underlying causes of the problem in healthcare and ask ourselves the following question, which is, if you were to look at what's stressing the healthcare system today and you ask yourself, why is Medicare, within 20 years of insolvency and all that, and you say, okay, well, population's aging, and as you pointed out, the aged consume more healthcare and whatnot. And if that were all the case, and the burden of chronic disease hadn't changed from when I was born, let's say in the very, very early 1970s, okay, we would not have an economic problem today. And the flip side is that if we had, and let me explain that for a second. So the rate of diabetes and obesity from 1970 to where we are today on a per unit basis in the population is somewhere between 300 and 500% of what we saw back then, okay? And so the healthcare system is not designed to deal with that, and neither are employers. My fundamental view is that if we really want to get healthcare costs under control, we have a behavioral problem. I don't mean a behavioral problem that people can't control the 5 cheeseburgers or whatever. I mean, that is a portion of it. But we also have an environment that we've created in which I would argue incredibly poor scientific research in nutritional science has promoted, essentially low-fat, high-carbohydrate diets for 25 years by, pretty well-meaning people like Dean Ornish and others that have created this obesity, diabetes crisis that we see that drives healthcare costs. I mean, there's no other way to look at this problem. And so if we had all of this aging and we didn't have any different burden of chronic disease than we had in 1970, we would be sitting somewhere below 14% of GDP today, which I'm not sure we'd all sit around and say is a big problem. Where do I think employers can help the most? Employers can help the most by promoting healthy lifestyles for their employees. It's the behavioral side of medicine. With all due respect, physicians are not the solution to this problem as we look forward. And I think the employers could play a huge role there. I don't think the employer's role is going to be, creating new healthcare marketplaces or new regulation that they lobby for that's going to make any difference in this environment.
Okay. Great. All right. So those are I got one question each. So I'm going to open it up for the audience. We've got a question right here, table 4. So wait, we've got a, yeah.
I go back to 1948 when the World Health Organization put out its definition of health. It's a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So with that, the challenge I have to you, for all of you, is health or health care a right or a privilege? And 2, how do we integrate the whole issue of health or healthcare with the 3 Ps, personal health, population health, and public health? Because you never hear about public health and how it interfaces with the insurance model and the like. So that's what I ask you. One, what's your thoughts on, is it a right or a privilege? And 2, where does health equity and social disparity fit into the equation? And 3, where's public health integrated into the solution for the health of all of us?
Good luck, Leonard. Why don't you take a stab?
Yeah, shortest guy. Yeah.
You're right next to me.
So, I would change the question. Is it a right, is it a privilege, or is it a responsibility? And I think where people up here would like to go is that we've got to create in the minds of the population that they have all of us have a responsibility to maintain a good health. The initial question, though, goes back actually to Senator Kennedy. Teddy Kennedy was the guy who posed this, and he said that it's a right, and therefore the federal government ought to expand, or state governments, or there ought to be assistance to people who can't afford health care themselves. I think the issue, though, is, and I think we will get to it sooner rather than later, is there are certain people are born with genetic predispositions, et cetera, accidents, et cetera, but by and large, how you live your life has a huge impact. And are we going to hold people responsible for living their lives in a reasonable way that should lead to better health for themselves and lower cost for the community at large? Unfortunately, most of the federal politicians, the federal office holders, Freudian slip, aren't interested in that question. But I really think that's the question. Do we end up, as the doctor said, with a situation where what kids learn in school is translated into how they behave? And I was involved with the no smoking thing, and we took enormous crap for that, okay? And what changed everything was not what we did, it was what kids were learning in school. And they came home and they said, "Mommy, why are you smoking?"
Right.
And Mommy had to hide the cigarette, and it changed America. I mean, nothing personal. 30 years ago, everybody would have been smoking in this room. Right. Nobody's got the guts to light up, and we know that 22% of you are smokers. Sorry, but nobody's going to admit to that. So I think the question you're addressing goes to the culture of health, which is now the big issue as far as I'm concerned.
Yeah, I agree exactly with what you said. I think, I've kind of thought about this for a long time, as all of us in this room have, and I'm a big personal responsibility person. I think we all ought to take more accountability, but I think the way the question is asked typically is it a right or a privilege? I think it's both, but I mean, even if you're a cold-hearted conservative and you'd say people should pay their own way, the reality is, if we don't have a health system that takes care of all of us, we all end up paying for it anyway. It just presents at a later stage when somebody goes into an emergency room having a heart attack or an advanced cancer or something like that, and there's no doctor or hospital that's going to turn that, well, there are, unfortunately, but, no decent one that's going to turn somebody away. They're going to take care of them, and who pays for it? All of us do by transfer of payments within the health system. So it's in our economic best interest, not just the social obligation that we have for our fellow human beings, but it's in our economic interest to have a coherent health system where everybody gets adequate care.
Saum, you want to?
Yeah, I'm not sure I have a lot to add. I think, I think the points made are exactly right. I would say that the second order implication of the answer to the question is what's the role of government? And I think the most effective role of government is to help set the public policy and the public health framework in which many of the things we're talking about can be impactful. I think if you look in just a little bit more detail, in 1954, the Surgeon General said smoking will, essentially lead to lung cancer, heart disease, and death. And to the point, nothing happened until it became, untenable to smoke in public, employers essentially said you can't do this in the building, started teaching it in schools. And if you just think about the few areas in which we have the opportunity for government to think carefully about the public policy, which in today's first world economy is really around nutrition. At the end of the day, it's really around nutrition. I mean, it is reasonably well accepted at this point, many of the things that I talked about around the scientific misgivings of essentially low-fat, high-carbohydrate diets and what the impact has been on American society that we're now, by the way, exporting to the rest of the world. That would be a terrific place for public health, public policy to really begin to evolve in order to try to reverse that trend over the next 20 years. It probably takes a generation to fix it, but it's our best hope of having any control on total healthcare costs.
Next question. Right over here. Her next. I promised her that I would.
Hi. It seems that no one is against better healthcare and lower cost. But as a healthcare entrepreneur, the problem is that lower cost is taking away the livelihood of someone. And that then transforms itself into formidable opposition, directly or indirectly, to whatever that cost saving is. So could someone please address how do you deal with that cost saving, which is revenue to someone else, which is livelihood to someone else, which is job to someone else, who then deploy so that you can't achieve that cost saving and therefore achieve the better health?
Saum, you want to take that one?
Yeah, okay. So, I think I pointed out the amount of job growth that we've seen in the healthcare sector, most of that being in the healthcare delivery sector post-reform. A couple of things I would say. First of all, so one of my parts of my job is to be out in various communities in the U.S. Visiting hospitals in all parts of the country. And the thing I would say, and by the way, hospitals, I may get this a little bit wrong. I mean, hospitals, if you look at the employee base, it's about 75% women, right? I think that's about right when you think about the nursing and nursing staff and things of that nature. And you spend time with these people, and first of all, you realize what a different life you live than they live, right? And how much they're struggling in these communities, and how much these jobs are not just their livelihood, but their family's livelihood. One of the things I would tell you is that, in an odd way, many of the, again, it's a kind of overgeneralization, disenfranchised men who are in very well-paying manufacturing jobs, it's their mothers, sisters, daughters, girlfriends, et cetera, that are working in healthcare and helping to sustain the family, while many of them working in very low-paying service jobs that don't provide health insurance. So when you really think about the healthcare economy that's evolved, it's not just the dollar flows, but the dependence on those jobs to sustain families all over the country, who, by the way, live very different lives than we live, is one of the big risks in tearing down Medicaid or defunding, to some substantial extent, the hospital industry. And it's why I come out largely where Charles comes out, which is regulation and policy will cause more damage. In general, I believe government will cause more damage, whether you believe in the ACA or some whatever version Leonard presented. Both of them cause damage in different ways. It's really the healthcare industry that's going to have to decide it wants to deliver better outcomes at lower cost. And by the way, that's going to require innovation and entrepreneurs bringing new things into the sector. But the healthcare industry hasn't decided that yet, because they're not measured yet on outcomes within any part of the sector in any sustainable way. So I think there's a big role for innovation. But I will tell you, your point on job loss, if what happens, the way the capital flows look, is going to be ugly, because that's where the job creation is. And these jobs are keeping families alive, not just individuals.
Well, there's another point to add to this, and that is hospitals are extremely powerful politically. And again, it has nothing to do with health care. Elected officials aren't terribly interested in the health care that's delivered. What it's all about is jobs. And closing a hospital, which I tried to do as a government official, is more difficult than closing a military base. I tried to close Brooklyn Jewish Hospital in Brooklyn, New York, and this was some 40 years ago. And I'm proud to say not only is it open today, but it merged with St. Mary's, and it's now St. Jewish Brooklyn Hospital or something. But the point of the story is it ain't about health care, it's about jobs.
Charles?
Yeah, I guess my response to that is, and you hear that a bit, I think if you just look at the demographics of our country, what's happening to us? We're all aging, and what happens when we get older? We require more health care. I gotta believe there's plenty of work to be done if we're doing the stuff that needs to be done. The problem right now is not that we're taking care of too many people doing the right thing that need it. We're just doing too much stuff that doesn't add value. Too many tests, too many back surgeries, too many hysterectomies, prostate surgery, whatever. We do too much of that stuff. With the aging population, there's plenty of room to keep people busy. Is it going to be painful in some communities where they're overbuilt in hospitals? Yeah, okay, if we got population decline or something. But overall as a country, is there enough work for someone like you who's an entrepreneur in healthcare to come up with new solutions? Absolutely, but one of our criteria before we're going to support Intermountain Healthcare is going to support innovation as healthcare. It's got to be good for patients, it's got to be good for caregivers, and it's got to decrease overall costs of care. Those are the kind of innovations we need to go after. There are just too many things. It's one more gizmo that this achieves some immeasurable benefit to the patient. I mean, immeasurably small, imperceptible benefit that costs way more, but it just sounds cool. It's a new gizmo. And you know, one of the scariest things about it, we didn't even get into it this year in terms of cost, is the astronomical, the unconscionable, I would say, increase in prescription drug price. Whether they're generics or new drugs, that is going to kill us all, because these are drugs that are going to be increasingly necessary to take care of the aging population in cancer, in degenerative neurologic diseases, and diabetes and all that. And when we get to the point that a year's worth of a chronic medication costs the same as the median family income in the United States, it's over. The numbers just don't work anymore.
One more question from Irina.
So I have a question about public policy aspects of this. So the market doesn't work very well. The federal government is going in a particular direction. What should or could states do in terms of making the market function better over the next 4 years or permanently?
Well, California has done a great job with the healthcare exchange. I mean, you saw the numbers up there. California has done better than almost anybody else in terms of simultaneously reducing the percentage of uninsured and maintaining some quasi-competitiveness in the marketplace. And I won't go into all the detail, but ironically, the California exchanges they are a bigger government effort in California than in almost any other state. There's more attention paid, there's more activity, there's more regulation, and if you get good people doing that, you get a payoff. It's not clear in other states that there's been the investment in making the exchanges work, or they've had the kind of quality people that California has fortunately had. I think, personally, what I think was going to happen, if there is a movement toward delegating authority and giving money to states in Medicaid, you'll see very different models emerge in very different states. And the theory of the case is the models that are accepted, that are successful, and one hopes in terms of outcome, will then be duplicated in other states. Ironically, that hasn't happened historically. I mean, Intermountain is not just good. These guys are beyond good. This is the best hospital system on earth, okay? But it's true.
All Charles.
No, it's true. We use the same system you did to give data to doctors. And one of the things that distinguishes physicians from human beings is they are very data-oriented. And if you show them data that they believe is accurate and timely, and parenthetically, if they get it from an insurance company, they don't believe it's accurate or timely, but if you can convince them of that, they will change behavior overnight. And you saw in 1 month, drop from over 25% to 5%. 1 month. I mean, you couldn't get that in any other business. But there are very few organizations that are invested in getting meaningful data to the decision makers. And if you try to get government involved in doing that, then you get even bigger pushback than evil insurance companies. But I think what will happen is there'll be different systems developed in different states, not based on healthcare, but based on the role of government, based on cost, based on social values, and some of them will work well, just like the healthcare system or the exchange system in California works well, and some will be horrible. And welcome to a federal government state, a federal government country, right?
Can I make
Charles.
just the briefest comment about that? You're very kind in your comments about Intermountain Healthcare, and my facial grimaces are just my discomfort, because I said, when you know the data, you know that you're never as good as you think you can be. And I can just, we've made some real progress at Intermountain over the last 30 years. But there are so many ways that we can and must be better. In healthcare, if you know you have the opportunity to improve, it isn't just about a business, it isn't just about money. This is people's lives and their health. And I get uncomfortable when anybody gives us too many compliments, because I can see how much better we need to be.
Saum, do you want anything?
You know, the only thing I would say is that in line with these two comments, one implication is, we have rich states and we have poor states, and we have low government intervention states and we have welfare states. And California is a rich welfare state, okay? And my view on that is that we will not build healthcare systems around the country based upon what rich welfare states can do.
No, I agree.
And the argument to move healthcare closer to the states is, in theory, they understand their population and employer environment better than the federal government. And if they use that information productively to design a healthcare system that's affordable, maybe consistent with the values of the people in that state, and deals with the underlying health issues that may afflict those states, which are quite different than other states, there is some hope that state-based healthcare can move things forward. Our big question in this country is really, if you think about it, the burden of illness is generally in poorer states with a mindset of less welfare. And if we don't sort out models that will work in that environment, whether it be the Indiana model or something else, we will leave a good portion of the population behind as some parts of the country continue to get healthier. And that'll be a problem. That'll be a real problem.